Hi, I'm Dr. Sunil Kumar K, Lead and Senior Consultant, Interventional Pulmonologist and a Lung Transplant Physician at Aster CMI Hospital, Bangalore. Today's topic for discussion is lung cancer. Lung cancer is the most common type of cancer diagnosed and leading cause for cancer-related mortality across the globe. In India, lung cancer constitutes more than 6% of all cancers and also contributing to nearly 8% of cancer-related deaths. Last year, we had 1.1 million cases which was diagnosed and also mortality to the tune of 7.8 lakhs. Now, with this sort of a lung cancer having so much of burden, what are the most common risk factors what they carry? No doubt smoking is the one of the leading cause for this particular lung cancer, and environmental tobacco exposure, air pollution, environmental triggers like exposure to asbestos, exposure to argon or radioisotopes, pulmonary conditions like chronic inflammatory like COPD, idiopathic pulmonary fibrosis, and some of the genetic causes which can contribute to the risk factor for developing lung cancer. When it comes to histologically of what is that lung cancer types, we have a non-small cell lung cancer and a small cell lung cancer, where majority of more than 80 to 85% is by non-small cell lung cancer, remaining less than 10 to 15% is by small cell carcinoma. In the last 2-3 decades, we have seen the trends where we are moving from a squamous cell carcinoma to adenocarcinoma. Multiple reasons: the smoking habit, the local BD, which all the one which will contribute to take the deep puff so that the central dominant squamous is more into a peripheral adenocarcinoma. As a screening modality, can we pick these people early? We have a low dose CT which comes up handy as a screening modality, but in India it's hard to apply based on the cost, availability and the interpretation because of the TB what we are going through. The annual screen is nothing but somebody who is asymptomatic between the age of 50 to 80 years and who has a smoking history of more than 20 packs per year qualifies to call for low dose CT as a screening modality. Now, if you pick up any sort of a nodules are small, less than 2 millimeter size lung lesions in a country like India where tuberculosis granuloma is also most common. Keep in mind, based on the pretext, whether the age of the person, the risk factors the patient carries in terms of smoking or any other comorbids. At the same time, a morphological feature of a nodule, size, less than 2 centimeters, less than 25 to 30% possibility of a cancer as compared to more than 3 centimeters. What are the borders, margin, what is the inside material like calcification, eccentric calcification, minimal calcification. All these things will determine whether this could be possible to have a benign nodule or a malignant nodule. Malignant nodule more than 8 millimeters definitely has to be worked up with a CT scan or serially by doing a PET scan to know whether the rate of progression is adequate for any sort of a biopsy which has to be done. When it comes to clinical features, maybe local pulmonology or extrathoracic manifestation. Predominant thoracic manifestation can be present with cough, breathing difficulty and a hemoptysis, nothing but blood in the sputum. When it comes to diagnostic modality, we have a chest X-ray as an initial screening. CT may not be so specific. Whole body PET scan is also one more thing when we have a high predicts possibility. The need of the hour, tissue is the issue for the diagnosis of a lung cancer, where histopathology through bronchoscopic biopsy and to have a mediastinal lymph node biopsy, we have endobronchial ultrasound. At the same time, any peripheral lung nodules, we have radial EBUS coming up as a handy option to biopsy this particular lesion, which is less than 2/3 of the lungs in the central part of the lungs. Peripheral 1/3, we have a CT guided biopsy comes up in a handy position. Previously, the school of thought where diagnosis can be ended by deeming atypical cells. Now there's a recent precise oncology which needs a more tissue to get this sequence of immunohistochemistry to get a precise things going on using a NGS also comes up very handy in terms of getting a proper treatment for based on the tissue what we get in a biopsy sample. Staging of any lung cancer is very crucial. No doubt TNM classified based on tumor size, lymph node status and a metastasis. We have a TNM staging into 1 to 4 types. 1 predominantly local, 2nd and 3rd loco-regional, and 4th stage is more of a metastatic. If you see the 5-year outcome of this particular thing, stage 1, 5-year survival benefit is to the tune of 77 to 80%. Second stage, we have 5-year survival to the tune of 55 to 60%. Third stage, we have 20 to 28% 5-year survival. And a stage 4 goes without saying, a distant metastatic less than 3% 5-year survival. Stage 1 more of a surgical, locally stuff. Stage 3 and 4 most of a chemotherapy. Stage 4 is only a targeted therapy based on the immunohistochemistry, what we get it, either EGFR or ALK, what is noted in the picture. Mind you, adenocarcinoma is more common in a people who is a non-smoker, female with Asian predominant, has to be kept in mind. At the same time, when it comes to future, your immunohistochemistry and NGS going to be having a major role to play in terms of targeting the therapies so that we have a precise, targeted, tailored approach to this problem. Multidisciplinary team discussion with the precision oncology approach would be the need and a key to the next level of cancer care in the lung cancer. Clinical and radiological follow-up is a key once you start with the medication. All these things can be comprehensively addressed at Aster CMI Hospital, including a multidisciplinary discussion teams, including spearheading with the pulmonology team at Aster CMI. Thank you.